Good morning, good afternoon, good evening to you all, wherever you're joining us from. Apologies for the delay, and thanks for joining this session of the webinar series. Today, we are going to talk about local initiatives in suicide prevention, the African experience, and we have Dr. Joseph Osafo with us. My name is Priscilla Osei-Bonsu, and I'm the research assistant for Partnerships for Life African region. So let me introduce Dr. Osafo, and we can begin today's session. Dr. Joseph Osafo is a professor in clinical health psychology, a lecturer at the University of Ghana, and the director for the Center for Aging Studies, University of Ghana. He has been engaged in cutting-edge research for the past 13 years, focusing on suicidality and related mental illness, adolescent sexuality, religion, and mental health, and marriage. In recent times, he has also ventured into child and maternal health. His research on suicidal issues has been recognized internationally when he won the DeLeo Award in recognition of suicidal research carried out in developing countries. He was a lead advocate in the decriminalization of attempted suicide, in Ghana in 2023. And currently, he is the lead for Partnerships for Life African region. So thank you so much for joining us, Dr. Osafo. You are encouraged to use the Q&A when you have questions. Stay glued in, and we'll have the presentation for about 20 minutes, and then we can take the questions. Okay, so Dr. Osafo, your audience, you can begin the presentation. Thank you.
All right, thank you very much, Priscilla, and thanks to the organizers of this webinar. Thanks for the opportunity to share, to learn together, especially those of us who have worked in this resource-trained and resource-poor setting in Africa. I'm going to be spending some time with you for us to look at this topic in detail. I'll be giving some practical examples from Ghana and Nigeria, maybe Uganda, maybe Kenya, just to push home the point of how local initiatives can be organized and maybe how effective they can be in light of unresponsive governments in sub-Saharan Africa, especially when it comes to suicide prevention and suicide initiatives. So we'll look at a bit of introduction, giving you just a bit of context. We'll look at local initiatives. I would want to define it. We'll look at its key characteristics. We'll look at the African context. Then sample of some community based suicide prevention programs. We'll look at the issues of evaluation and outcomes, whether we are even able to do that. And then some lessons that can be learned, and then we can draw some conclusions. Now, we all know what is happening in the Africa region currently. The global standardized suicide rate is around 8.9 or 9% per 100,000. If you look at that of Europe, Eastern Mediterranean, Southeast Asia, Americas, and Western Pacific, Africa, according to the WHO's report, is high. It's around 11%, and that is even higher than the global average. And so for some time now, the focus has been on Africa. In fact, some have taken, for instance, adolescents issues and those in school issues seriously, because if you look at some of the rates among young people within the Africa region who are killing themselves or engaging in suicidal behaviors, this can really be difficult and quite problematic. Ghana, for example, is looking at a rate of about 20% of young people who engage in suicidal behaviors. And so Africa is now in the limelight, especially when it comes to suicide. And therefore, suicide prevention is very key for us. Now, factors that are driving this behavior within the Africa region range from poverty to cultural norms. There are varied factors, trauma at individual level, economic crisis, financial difficulties, unemployment. Some studies have even examined, for example, adversities among young people, adults. Recently, in Ghana, we have began looking at, for example, aging and suicide among older persons, 60 years and beyond. And quite interesting that this population, the feeling of isolation is driving them to wanting to, for example, take their life. And so the factors are quite myriad and numerous. And that should give us just a quick introduction to why Africa is currently under the radar, to look at what is happening and to see what can be done, especially when we have unresponsive government in most sub-Saharan Africa on an issue that is deemed very, deeply stigmatized. So local initiative, LSPI, what are local initiatives? Just to differentiate that from national level interventions. And I am very much interested in doing this, differentiating that, because oftentimes we want the top down approach. Over the years, from my work in this field within the Africa region, especially in Ghana, has been advocating for a bottom up approach. And this particular presentation is within that model. I'm looking at a bottom up approach where we are not just talking to African government to begin to do something until anything is done, because that, I have argued elsewhere, is going to take us years to see that materialize. So I'm defining it as a community-based grassroots approach that engages local stakeholders and leverages existing community resources and networks. When I began working in this field, then I saw the daunting task of wanting to just go the top-down approach. You can break your back, because it is so stigmatized that if you want to create any critical mass of advocacy, of impact, you're better off starting from the bottom and go up. And so the aim usually for local initiatives, the aims are often to create awareness, to reduce stigma, to improve access, and to provide support. For example, in some communities where people have lost words to suicidal behaviors, what they go through in the hands of community members alone is enough to trigger suicidal crisis in them. Usually, LSPIs have the following features. They are community engagement and ownership. So by the time you roll out, you will see that the community can take it over. So they are part in even describing and initiating such an intervention. They are often culturally sensitive, and they will be tailored to meet the particular need and norms and values of the community. I remember working in one community, and when we got there, we would have to, as it were, respond to the expectation of the communities in going through various layers of having to, for example, pray, pour libation, and get to the community leaders, because the issue we're going to be talking about was seen to be very loaded and heavy, that required that we did that. And so it's often tailored to respond to norms. Not only that, it is often multi-sectorial. Usually, local initiatives will be bringing together on board. So, for example, in my work in Ghana, and somehow I'll be mentioning from Uganda and Kenya and others, you will see that people are bringing on stakeholders. They are talking about school leaders, for instance. We're talking about businesses, talking about faith-based organizations, some of which in one of the, webinars I did mention and show how, for example, we have worked with faith and traditional healers in Ghana to push for advocacy and to widen the scope of awareness creation. Not only that, they also often capacity building and empowerment oriented because sometimes you have to train. I remember, for example, in Ghana from 2015, no, 2012 to 2019, we had sustained training for gatekeepers for about 7 years. We kept on training gatekeepers, community leaders, queen mothers, police officers. We kept on doing that. We were building capacity so that when we are not, they could take up that. And I think that in one of the webinars that I presented some time ago, 2 years ago or so, I showed how we build the force from below instead of from the top. Okay, so it began gathering momentum from below up. And so oftentimes local initiatives are focused on capacity training, building capacity within the community. And also they leverage existing resources and networks. Okay, what they do is that they are going to be leveraging on the resources of the communities, the community programs, the social connections. Just imagine running a program on suicide prevention in a community where you have a church that has more than 4,000 members. And then you get into that church and you have about 30 minutes to speak about suicide. You have a captive audience. That's the first opportunity and the resource you have. You have a captive audience who may even engage you by asking questions. And you have people who may approach you right after. And this approach is very incredibly powerful from my experience in working in Ghana. I see that Kenya, I'll get there and show you, Kenya is beginning to do that. And I really commend Kenya for doing that because Africa is a religious powerhouse. And a lot of people are in there who could easily be trained and who could easily become resource persons and who could easily become point of networking to build resources that can really ignite local initiatives. Also, local initiatives address social determinants of health because what they do is that they will recognize and aim to address certain broader, social, economic, and environmental factors that contribute to suicidal risk. I work in a community in Ghana where the chief called me and said, could you come over? We have a number of young people who are attempting suicide. And so when I got there, I discovered something very interesting. The young people were, a couple of them, about 4 of them were attempting suicide because they had gone for a loan. These are local schemes to help young men and women who want to get into agribusiness, for example. And so they go for this facility, and then they are into perishable productions like tomato, like onions, and what have you, but they don't have means of storing them. And so once they harvest, they have to sell. The market must be readily available to sell. If they don't, what it means is that they are unable to go for their, to pay for the money that they have gone for, the loans. And this is a real problem. So because they could not pay, the best way they thought was to end their lives. Okay, so when you initiate local interventions, for example, you are able to get into these determinants. And these are unique determinants you may not pick up at the national level. It's when you are working at the local level that you could pick some of these unique determinants. And of course, you can go there, easily evaluate easily go and check after you have done what you did, what happened, how many people have, after your interventions, have taken their lives, what is happening. Are people now opening up for support? And it's quite interesting to see and assess the effectiveness of your intervention. It could be a church setting, it could be a workplace setting, it could be a very small community village setting. And then whoever invited you will tell you, for the next 4 or 5 days, or 5 years or 3 years, we haven't recorded this. People are now opening up, they are sharing their thoughts, and they are coming up for support. So these are the general features of local initiatives, but generally they are very important. Local initiatives are extremely important, especially in resource-strained countries like Africa, because as we know, generally national level interventions may not fully address all the issues we are looking for. And if you come into our settings in Africa, African governments are not even ready to, as it were, fund programs. And I have been in this since 2008 until now. All the funding I've gotten to do interventions have never come from African government, none from my government. I've looked elsewhere, I have appealed to, individuals who are philanthropists, I've collaborated with people outside. So if we want to really work and reduce the rate at which young people in Africa are beginning to, engage in suicidal behaviors, I have always said again, and let me repeat, that taking it from the top down is a daunting task. So local initiatives often create, they are tailored to the needs of the specific, communities, and they are very vital. In fact, in sub-Saharan Africa, they need to collaborate, they need to get multi-stakeholders, they need to work within communities, cannot be overemphasized, because in Africa, we lack most government responsiveness. And so local initiatives become extremely crucial. They're also very crucial because the socio-cultural factors that are influencing suicidal behaviors in Africa remain very strong. Recently, there was a review, I think 2023, a review that is looking at, for example, countries that criminalizes suicide and the rate of suicide. And the findings are quite interesting. The finding was such that in countries where suicide is criminalized, the rate is high, but the rate is further high among women. So when we say we decriminalize suicide, it's a very key way of fighting or of attempting to reduce, for example, suicide. So the sociocultural context is very powerful because stigma continues. And in fact, the role of traditional beliefs in some areas in Africa, when you die, the role of some traditional beliefs must say that you must not even campo. Those who have lost you, the grieving, they don't go through the full, length of grieving because the systems will not allow them. And again, in most African countries, criminalization continues. Thankfully, Partnership for Africa, Partnership for Life in the Africa region is working assiduously with countries. Nigeria is pushing hard. Kenya is pushing hard. Very soon, others will join Ghana. We hope that this will work. And so there are also challenges in accessing mental health services. And so local initiatives become extremely important because there is limited availability. In some communities, you may not even get human resource. I'm talking about professionals to work with suicidal persons. But when you build a local capacity within the communities, then you can get gatekeepers who are available, who can, for example, be of help. Now, I'd like us to understand a bit of the African sociocultural context. That at least can give us some very good understanding of why local initiatives are very key that I think that we should consider. First and foremost, there is a huge lack of national level data in the surveillance systems because as I said, most sub-Saharan African governments are not very much committed to taking bold steps in improving, for example, the mental health of their populations, and especially targeting suicide. So that is a problem. In fact, we did a study in 2020. It's published in the Crisis. There's no national level efforts to monitor and address suicidal problems in most African countries. In most African countries. The other one is that usually there are challenges in implementing national initiatives. And some of those challenges are such that you don't even have the human resource, the funding to do that are not there. And on even distribution of resources and efforts. If you come to Ghana, for example, you would see that almost all the mental health facilities at the national level are all at the southern part of the country. It was just 2 years ago, again, local initiatives, through our effort in working with the churches, that the Presbyterian Church of Ghana went to the northern part of the country, the Upper East, and set up 10 to 20 bed mental health, structure. It was through these local efforts, so that we can, for example, trigger responses from some of these stakeholders. Don't forget, I said this local effort. We're talking about stakeholders, local stakeholders coming together instead of we looking at, for example, African governments or at the top political level. I'm not saying that the politicians are not needed. They are. But the point I'm making is that if we are looking at speed, then that is not the way to go. That is going to take a lot of time in Africa if you're looking at the top-down approach. In terms of speed, the bottom approach is better. So the Presbyterian Church, for example, built one. As I'm speaking now, the largest Pentecostal church in Ghana, called the Church of Pentecost, is also almost replicating that in the middle part of the country. They are also, for example, building they are building what we call, it's for drugs, a mental health, drugs rehabilitation and mental health unit. That could have close about between 50 and 100 beds. These are all local initiatives that are actually resulting in this. So the uneven distribution is a problem. Now, usually, in all of this, we have attempted through Partnership for Life in the Africa region, through our regional level webinars that we have done over the years, for the past 3 years, to trigger in our members within the Africa region of the need to take this bottom-up approach, because that's where we can have and make some impact. I just want us to look at some of the existing local prevention initiatives within, for example, the Africa region. So I want to just give examples. So Priscilla, you can move to the examples. Let's start with Ghana. So let's look at Ghana. I'll look at Ghana, I'll look at a bit of Nigeria, I'll look at Kenya, I'll look at Uganda. I just want us to see how some of our colleagues in this centers are beginning to initiate something. I wanted to share something on La Côte d'Ivoire. La Côte d'Ivoire is also doing something very fantastic by the time couldn't allow me. But let's begin from Ghana, for example. Now, as I said, right from my PhD, I saw that if we wanted to go the top-down approach, there was going to be a huge problem, because and anybody at all can check on me. I've done a publication on suicide and stigma, and I indicated in that paper that suicide in Ghana and arguably most African countries appears to be stigmatized at 3 key levels. The first one is at the local religious, societal level, local community level, where traditional leaders, family leaders are highly opposed to this. And if you found yourself in a crisis, you may not get support. The second is at the religious level, that in almost all the 3 key huge religions in Africa. I'm talking about Christianity, I'm talking about Islam, I'm talking about traditional religion. Everyone is opposed. There is this convergence of condemnation from them. But the third is quite the most disturbing, which is at the political and the legal front. So, for example, in Ghana, prior to 2023, we had a code that condemned persons who attempted suicide. And so even at the state level, it was still condemned. So if you want to even talk about this, I can tell you as a worker and a researcher on suicide, I went through difficulty taking this matter to politicians and even to legal practitioners. How will they understand me? I'm likely to be misconstrued. So in Ghana, what we did first was to look at local researchers at Eugene, at the University of Ghana where I work. I put together a team. And what we did was to begin to run training for community leaders. So we started the bottom-up approach for traditional queen mothers, for religious leaders, for judges, for police officers, for school counselors, for media. And this was sustained for 7 years, constantly doing this. We began shaping the base, and that's how I call it, shaping the base. Because usually, if you look at the cone, the base is quite broad, it's big, and the top is narrow, like a pyramid outline. So we're shaping the base. And the point was that if we got the base very well, fertilized in code, well, imbued with proper understanding of suicidal behaviors, then of course this could be going on. So for 7 years running, that was the first that we're doing in Ghana. And then our advocacy engagements began. So once we filled the base, we began, for example, running advocacy with politicians. I had a chance to engage with Parliamentary Select Committee on Health, the Parliamentary Select Committee on Children and Women, because we had data on children and women and suicidality, the Parliamentary Select Committee on Legal Changes. So for about 2 years, I kept engaging them. And I had a rare chance, and I said this in one of the webinars, that we were able to, for example, train over 247 judges from the lower court to the appeal court on suicide and the need to decriminalize. I thought that was the most incredible experience we had. We also began doing something on, for example, media. And I'll tell you about the media, how far we have taken it. Currently, for example, when you go to, so that's what about advocacy. When we go to the media, I'll tell you something that is coming up when we are getting up. So we began the advocacy. And so the media space began to be filled up with a lot of issues on suicide. We began building collaborating with various stakeholders within the field. So psychiatrists, social workers, medical doctors, nurses, all of them, we're engaging them. Then we started a community education. So I began going to communities with my team and then began organizing training within these communities. First was to find out what was happening, but to be able to have the real impact, we wanted communities where suicides were occurring there, so we could check and see what was happening. So we went to some communities where the chiefs called us and said, look, we have cases like that, and went there, and then began rolling out interventions for them, setting up support systems, and then giving them access to reach us anytime people were in trouble. So that was the community education engagement. Then the media training, we took that also very serious. And these were all local initiatives, no government sponsorship, local initiatives, and building networks. And then again, the media, we began looking for support. We got rare support at this time from Lifeline International, who invested some money because we had done initial study. We wanted to develop our own scorecard for assessing what is happening in the media landscape within Ghana and how to make sure that the media publishes stories that are rather suicide preventive more than rather creating sensationalism. I'm glad to announce that we secured another funding through WHO to expand and scale up that local initiative. And so WHO has just awarded us some funding to build on that. And so we are going to train more and then test and see what is happening. Now let's talk a bit about Nigeria. And Nigeria has a number of organizations. SEPIN is one of the biggest in Nigeria. ASA's Anti-Suicide and Depression Squad, Money Mentally Aware Nigeria Initiative, and then the CHILD, Center for Health, Ethics, Law, and Development, and others. But these are some of the things, some of the huge local initiatives that are ongoing who are equally working within communities. For example, I'm reliably informed that SEPIN some time ago began training religious leaders. And I have said this over and over and over and over. If you look at the resources that are available to Africa in terms of religious leaders, I think it's incredible because they are in every nook and cranny of the continent. And if you are looking for people you can easily train and for example, ask them to detect warning signs and to shape their attitude so that they will have willingness to support persons in suicidal crisis, I think Africa has more than any other continent currently. And religious leaders are good in this. And so Nigeria, SEPIN took opportunity and began training them. The idea was for them to identify suicide warning signs. That's incredible because we have done one in Ghana and it's so effective. The calls you get from them about persons who are going through crisis is incredible. You may not get that if you did train mental health workers and you ask them to refer. These guys, when you train them and you shape their attitudes, will call and they will refer. And all you need is to let them refer, provide initial support and let them refer. And sometimes they don't even refer. When the support is about adversity, now the person is going through some distress, they are able to show some support that can ignite hope in the person. And then that is it. And so SEPIN from there reported that there was a regular referral. When they did a training for religious leaders in Nigeria, there was a regular referral. I attended one program in SEPIN last year, incredible, online. So SEPIN is a big local initiative in Nigeria. When you look at Uganda, for example, the Gulu Sheffield Mental Health Partnership is one popular program where colleagues from Sheffield began joining others from Gulu. Gulu is about 350 kilometers away from Kampala, the capital of Uganda. And it's a post-conflict area. After 20 years, there's a lot of trauma in there that is driving, for example, a lot of mental health problems and suicidality. And so Sheffield partnered with them and they began handling suicidal behavior within the place. And so they trained and empowered primary healthcare workers. This is a very beautiful program. They empowered community leaders to have who have influence on how people can seek help. And then also supporting bereaved families. And it's just incredible. Another example of a local initiative. Kenya recently began the Ministry of Health and the mental health. This was 2025. And I'm really, really glad when I saw this because I think that these are resources that we have within our context. So Kenya, for example, the Ministry of Health, especially the mental health unit, in collaboration with the National Task Force of Mental Health Organization, began rolling out a training program. The objective was to equip religious leaders with basic knowledge and practical skills, especially on how to recognize suicidal signs and then how to offer crisis to persons who are in such how to offer support to persons who are in such crisis, and then also facilitating referrals. And incredible. I mean, it's quite interesting. So Kenya is also beginning to look at this, and I think this is the right approach. Now let's run up and look at some challenges and barriers that have often been found. Stigma and cultural taboos continue. Most African countries are, for example, decriminalizing. But one of the huge problems that hopefully next year we are going to be tackling is specialized programs to reduce stigma at the community level. At the national level, it's been knocked off, but the stigma still lingers. And then, of course, limited resources and funding initiative, which I mentioned. Then coordination and collaboration among stakeholders. Sometimes the coordination becomes a problem because you are looking for the right people to coordinate with. But there are actually promising own them. The one we did in one particular place in Ghana, for example, it's been the community that has owned it. The chief himself is the one who will be finding out to see what is happening, telling me what is happening, and it's just incredible. Again, adapting interventions to the local context. You are able to adapt it to the local context, and that is also very interesting. Then, of course, you are able to leverage the existing community or community structures and resources, because that's where you are building the resources. And then you strengthen partnership and data-driven approaches. I can tell you that the opportunity we have had in Ghana when we went this way was because we have had partnership with these leaders in the communities, that if you are rolling out any local intervention and collecting data, you really have access to go and collect data. Now, as I draw the curtains for us to interact a little bit, what are the recommendations I'm making? The first is that I'm thinking, and I recommend strongly to my colleagues within the Africa region, that currently Africa has the highest suicide rate than any other region in the world. We need to develop culturally appropriate interventions, and we have to start at the community level. I still say, let us not look at the global north in sinking money here. That will take a long time. Let us not look at our government to say they will. We should engage them. But whilst they haven't responded, let's begin in our communities. Let's begin in our schools. Let's begin in our churches. Let's begin in that particular vicinity you live in, and empowering our communities to build capacity. And let's begin to look at fostering multi-stakeholder collaboration, very, very important. And then also improving our data collection and monitoring system. For example, one way of doing that, those of us who are working in the communities, and the school is a community. My team, for example, has collected the largest data sample on suicide in our universities in Ghana. That's a community. And that is going to be shaping, for the first time in Ghana, we have the evidence to begin to draw intervention programs starting 2026. So let's begin to look at this. Let me take the next 2 minutes. Priscilla, help me on that. 3 minutes to run up on this, because I really want to do this one. So please help. I'll finish in just 3 minutes. Now, advocating for increased funding and policy, we have to do that. We have to do it. But like I said, if we are waiting to get funding before we do something, the African story of suicide prevention may not be the best. So in conclusion, I am simply asking for what I call tax sharing and tax shifting. Tax sharing and tax shifting. I'm just saying that instead of looking at suicide prevention from the national level, let's begin to look at it from the community levels. Because the national level prevention and the community initiatives, they are different in some level. Number one, the scope and reach. At the national level, the focus is on a large nation, everyone. And that will require resources and a lot of things. But if you start at the community level, you can reach out to people. Again, if you reach out at the community level, there's community engagement. There is still an approach at the local level. You can leverage your resources and you can address practical, some determinants on which you can, for example, prevent suicide. On that note, let me draw the curtains and then I yield to Priscilla and we can pick some thoughts. Thank you.
Thank you so much, Professor Osafo, for this presentation. We thank you for sharing this inspiring work. Can you speak about the suicide death surveillance system in Ghana or any of the African countries? So, Dr. Osafo, can you speak about the suicide or death surveillance system in Ghana or any of the African countries?
So thank you very much. So that's one of the challenges within our setting, because we don't have very much response from most sub-Saharan African governments. The systems and the structures that can help us, for example, to take up data and then to monitor what is happening and use that to guide and gauge prevention is still poor. I am reliably informed, for example, in Ghana, that the Ministry of Health started something, but along the way, God still curtailed. The plan is that once you get the enthusiasm building up at the base, currently, for example, the team in Ghana, for example, is looking into 2026 as an intervention period where we want to roll out intervention. One of the things that we want to do is to collaborate, look for it to collaborate with Mental Health Authority and other stakeholders. Am I back? It looks like my line dropped. Am I back?
You're okay, Joseph. We can hear you.
Okay.
Yeah, you're okay.
My line dropped here. So one of the things we're looking forward to do next year is to see how we can set up such surveillance systems within Ghana. I am also informed that in Kenya, Nigeria as well is looking into that. But that area is a big challenge within the Africa region. And so if you are looking for data to guide prevention, you may as well fall on cross-sectional studies to tell you what is happening among various cohorts and groups of at-risk populations. Thank you.
Thank you. We have some more comments. Decriminalizing suicide takes a step at a time. For example, we don't say commit suicide, we say take one's own life or end one's life. The word commit is criminalizing on its own. Yes, thank you so much. And these are some of the efforts that we make, especially in engaging the media, in reporting and suicide discussions. Thank you. We don't have any more questions. Let me just check the chats. Okay. I think from Sandra, I think the use of the gatekeeper approach in suicide prevention in the African setting should be highly prioritized. Having stakeholders facilitate and be forefront of suicide prevention will break the stigma chain and open the conversation. Yes, indeed. Thank you. Feedback from Christine. Thank you. Without strong surveillance system, it's obviously very challenging to capture accurate suicide rates. Thank you again for your dedication to making these many advances in Africa. Okay, let me quickly check the Q&A. I don't have any questions. Okay. John Bosco says, what was your experience with local fundraising efforts to drive your foundational work in Ghana before the external funding? Are there any lessons that you could share with other countries? So, Dr. Osafo,
Very much.
another question.
Very much. And Priscilla, I think that's one of the one very important question. Don Bosco, thanks for that. And I know Don Bosco is doing a great job in Nigeria with our team. Don Bosco, I will share a lot of things with you privately, but let me share some for the sake of all of us here. So one of the things that if you are going to engage in initiate a local approach towards suicide prevention is, for example, to speak to individuals, seek to persuade, seek to shape persons who, for example, could be philanthropists, seek to shape their thoughts on the matter first. So, for example, I've had one-on-one meetings with persons whom I wanted to fund, for instance, gatekeeper training. I got into the person. And number two, please go there with evidence. Go there with evidence. Don't just talk on top of your head. They want data. They want statistics. And so I went there with data and I said, okay, look at this number. I'm seeing this. And I think that I can make an intervention. And this is the intervention I can make. Number three, when you make the intervention, please give them a feedback. So, for example, take pictures. Number four, invite someone from the person who wants to sponsor to be part of the training so they can go and report and tell them what happened. So, and then also as you progress in this, always don't forget to recognize and acknowledge their support. So in Ghana, those of you who have known Jospong Group of companies, they have been my first support that I got in doing initiating local interventions in Ghana. And they kept doing that for about 2 years. They would try and give us resources, hire a place, train people, bring them back, but give them feedback, give them a report, let them see the progress. When you do that, you are able to mobilize resources from within. So the Moscow, very important question, and I'll share some other things with you. And I know that the work we are doing in Nigeria is incredible. You and Titi, thanks so much for working hard in this area. Okay, somebody says, I have, thank you with that strong, okay. I have this conversational languages used in suicide and its sensitivity with many media houses. Okay. And bloggers in Nigeria, it's a huge gap. And due to their outreach and coverage, they need to join the fight on stigma. This is from Nkoro. Okay. So let me quickly respond to that. Okay, Sandra. So the good news is that Ghana is building a scorecard. We're training the media and building a scorecard we think we can share with our colleagues within the sub-region. So very soon we'll be doing a training on that at a local level. We want to share that instrument with you to check. You can use it to check what is happening in Nigeria and pick up, because Nigeria and Ghana are very much alike on a lot of things. Of course, there will be a few variations, but we'll share. So that's a very good thing too.
Thank you so much for joining. We appreciate this. Thank you so much, Dr. Osafo, for the insights you shared. Definitely, suicide prevention should also be from the bottom-up approach, and you shared a lot. Insights in Ghana and other neighboring countries in the African region. And by leveraging on these support systems, we'll be able to drive suicide prevention within the African region and beyond. And I hope we've taken a few insights from this presentation, and we hope you to join the next session of our webinar series. Thank you so much.